everybody that's joined us and let you know that we will also be recording this session. So if you have folks that want to listen in at a later time, it'll be on the YouTube channel under Constellation Quality Health. I am Peggy Peterson. I'm one of the nurse quality consultants, and I'd like to introduce our speaker. And I will also note that as we go along, if you have questions during the webinar, please feel free to drop them in the chat and we will address them as we can with our speaker. This time I'd like to introduce Alicia Pichel. Alyssa is the Vice President of Operations at Constellation Quality Health, where she oversees organizational operations and program delivery across the enterprise, including the Quality Improvement Division. Her leadership ensures strategic alignment, operational excellence, and cross-functional collaboration through the organization's service lines. With extensive executive experience in post-acute care, Alyssa has held leadership roles across skilled nursing, hospice, and assisted living settings. She is known for navigating complex, highly regulated environments with expertise in strategic operations, total quality management, and healthcare payer systems. Her results-driven approach promotes regulatory compliance while advancing resident outcomes, customer satisfaction, employee engagement, and organizational performance. Alyssa holds a doctorate in healthcare administration and is a licensed nursing home administrator. Her professional credentials include certification as a Michigan Quality Examiner, a certified Eden Associate, certified Theta Learning Associate, and Six Sigma and Lean Six Sigma White Belt. Thank you, Alyssa. And Alyssa is going to speak to us on regulatory readiness, key insights into the top 10 regulatory citations. Thank you.
Thank you, Peggy. Appreciate it. Good to see everybody this morning. This is one of my favorite meetings to attend, so I'm happy to be here with you and would welcome the conversation. So please join in if you're watching remotely on the YouTube channel. If you have thoughts, questions, or need assistance, please let us know. We're here to help. As Peggy indicated, I have spent the majority of my career in the post-acute care division and am a strong, passionate advocate for what we do and who we serve. So it's always exciting to be able to talk about what's near and dear to my heart. As we look ahead for our time together, wanted to go through what the top 10 regulatory citations are that we see currently happening in the country. I ran the list yesterday afternoon, so we've got the most up-to-date and current information that's out there. Interestingly, it does not change that much through the year. We get some movement happening, but generally speaking, this has been what the focus has been throughout the year for us. Regulatory citations and the regulatory process can really have an impact on us and how we're managing strategically. It can really be distracting from a survey perspective when we have visitors and guests in the house. And so when we're thinking about how to work through regulatory citations, there's a strategy that we can implement. So knowing what those top citations are, exploring what the common cause of deficiencies are, and then developing our plan on how to manage that or mitigate that impact can help us to have a little bit more control over what we're doing strategically for the organization and able to manage what we can tend to see as uncertainties, have a little bit more control in that and allow us to keep focus on what we're there to do, engaging and supporting our staff, developing the relationships and providing great care to our residents and having good outcomes. So if you have thoughts, if you have questions, if you have suggestions on what's worked for you and your organizations, jump in. This is a great conversation for all of us to learn from each other. Okay, so the top 10 citations as of last evening, in numerical order, F880 for infection prevention and control remains the top cited deficiency in the United States, followed by 689. This one moved up in the ranks into the top 10 since June, since last time I ran this. So this one has been sliding up. Food procurement, storage, prepares, and serving sanitary conditions has remained in the top 3 spot all year long. 684 for quality of care, 656 for developing and implementing comprehensive care plans, 761, the appropriate labeling, storage of drugs and biologics, 600 for freedom of abuse and neglect, 755 for pharmacy services, procedures, pharmacists, and record management, 695 for respiratory, trach care, and suctioning, and 677 rounding out the top 10 for ADL care provided for dependent residents. I will tell you, I was surprised to see 677 make it into the top 10 this year, but not overly surprised. It's interesting that it's moved up in the ranks, and it's just demonstrating what our focus should be on as we look at the top 10. What should we be looking at, and how should we be ensuring that we're supporting our residents and our staff, the care and the systems that we provide? Where would I be if we didn't talk about what the top 25 was, just to give you a nod? I think that's important to everybody to have that awareness of what other opportunities are existing. So starting with number 11, 609 reporting of alleged violations, 580 notification of changes, 584 safe, clean, comfortable home-like environments, 686 the treatment and services to prevent and heal pressure ulcers, 842 resident records and identifiable information. That one is such an easy one that we see so frequently. Even just with new people coming on board and into organizations, of keeping those computer screens blocked or closing those down. Such an easy citation to obtain. 657 care plan timing and revisions. 641 the accuracy of assessments. 658 services provided to meet provisional standards. 580 notification of changes. 610 the investigation, prevention, and correction of alleged violations. 690 bowel and bladder incontinence, catheters, UTIs. 760 that residents are free from significant med errors. 692 nutrition and hydration status maintenance. 558 reasonable accommodations and needs and preferences, and 759 freedom of medication errors, 5% or more. Not to worry if you're trying to write these down quickly or taking screenshots. Olivia will send the presentation out to everyone that's registered, so you'll have all of this available to you. But if you feel free to do those quick screenshots as well to help you have that information. Again, this was as of last night, so we can see what the top 25 citations look like. So there's common causes that we see when we look at that list. My brain starts grouping those together and just seeing how we can tackle these. And I'm certain you're probably thinking the same way. But when we think about what are the 5 drivers of noncompliance, or the drivers of noncompliance, we really get this list. They're staffing, understanding resident needs, the infection control systems, protocol deviations and safety risks, supervision and accountability, communication and collaboration, resident, family, and staff engagement. Sounds easy. If we do these things, everything will work out. But we know that it's more complicated than that. We do have the opportunity to look at systems, and we do have the opportunity to look at what are contributing factors that can lead into these areas. And so when we have our systems in place, when we have our processes in place, we can help to mitigate the risk of these compliance drivers. The other opportunity that we always want to do, and it rings in my head as a baby administrator, hearing if it wasn't written down, it didn't happen. When we're working through these systems, this is a great opportunity to bring it into your QAPI. Take credit for the work that you're doing, document how you're doing your assessments, pull it into your QAPI, and then you have that available to demonstrate how you're actively working through a quality assurance and process improvement system. So staffing challenges. Some of the drivers that we see are insufficient number of staff to meet the resident needs, gaps in training and clinical competencies, poorly defined assignments and responsibilities, lack of mentoring or preceptor models, staff turnover and burnout. Not surprising information, but if we stop and think about how we may have been working our systems following the pandemic, some of our systems have slid a bit. I know as an administrator walking into facilities, one of the first steps that I would do was ask about what is our orientation policy. and talk to the team leads and talk to our scheduler, talk to our staff development coordinator if we had one, and understanding what we're doing. If I heard the phrase, well, they're an experienced professional, so we can have them oriented in a day, that rang a bell to me. First and foremost, it tells me that we're not honoring our commitment that we have to new employees that we are bringing onto our team. Our commitment is that we want to provide you with the services, the training, and the systems to be successful. If we rush through orientation and have you on the floor quickly, how are we following through on that commitment? So even if somebody has been in a position for a has been licensed or certified for several years, they still don't know how we do things in our organization. They don't know our individual culture. They don't know our residents and our families. They don't know our external team that we work with, our physician services, et cetera. So we want to make sure that we provide that pathway. We honor that commitment to our employees by providing that service and that training. It does mean that in those beginning months, as you're trying to get back on track with it, that your training does take a little bit longer, but your retention levels are going to be higher. When we look at assignments, we're trying to understand how the work is being done. One of the facilities that I worked in, we had an opportunity where we saw that our retention rates were pretty strong in the organization, but our turnover numbers were pretty high in one specific area. And we were able to get down to the point that second shift on these two positions on one unit was where all of our turnover was happening. So that led us into looking at what was going on. We found that our acuity, and not just acuity from what clinical conditions may be, but the behavioral and mental health support that we needed on that particular area really had an impact on the retention of our staff. So sometimes it's checking in and validating with our scheduling team that we're not just scheduling based on number, that we're looking at what the acuity is, that we're looking at what the time needs are, and that we're working with our frontline team members to understand what those shifts and changes look like. It may be fine in one quarter, and 2 quarters later, we have a significant shift that's occurred. So being mindful and keeping an eye on that helps us to ensure that we're meeting those needs of our staff and maintaining those relationships and maintaining those amazing resources that we have. Understanding our resident needs is another driver of what we do. And when we see in those non-compliance areas, we know that our surveyors are going to be going through and talking to our residents. They're going to talk to our families. Our residents are going to tell them what their experiences are. And so as a proactive approach, think about what your systems are in place in the organization and how you're checking with your residents. I've heard it called as guardian angel rounds or priority rounds, friendship circle. I've heard lots of different terms, but the focus is having a check-in set up with each of your residents on a regular cadence to just see how things are happening. How are things going? Are you having any challenges? Are there any staff members that I can recognize for going above and beyond? Bring your residents in and helping to acknowledge your staff and celebrate your staff gets them away from being focused on the problems and starts getting focused on what the solutions are. And then we're engaging our residents and moving the work forward. Talking with our team members about our care plans. Twice a year, one of the facilities I worked in, we printed off our care plans and gave them to the frontline team and said, what's right, what's wrong? That was our double check from our nursing assistants on, I'm seeing changes. I'm seeing that this isn't happening anymore. Or Mary's needing more help than she's used before. So we're engaging our family, our staff in on the care planning process. And we're keeping our care plans updated and accurate. Lack of documentation for our psychosocial needs. This is an ongoing opportunity. As we're rounding, as we're out and about, we're checking and validating that we haven't just normalized behaviors. A great corporate compliance director I worked with, Jen Brown, used to say to me, if you were standing in line at McDonald's and somebody was behaving this way behind you, would you stop and turn to see what they were doing? If they are, then we need to make sure that our team is documenting and capturing that so that we can have the documentation to show what's going on and demonstrate those acuity levels. Understanding what those drivers are of the behavioral causes helps us to minimize or mitigate. So the facility that we had a bunch of turnover on the area, we found that those residents were building off of each other, and especially sundowning time. So the sundowning residents would start having behaviors and confusion. Then they would start acting up a bit, and then their neighbors are yelling at them about them acting up a bit, and now it's just causing this chaos. So we were able to make some room changes to reduce some of that impact and still ensure that we're providing good care for the people on those units. The social determinants of health have been a part of what we're doing in the MDS for a couple of years now. And I think it's moving away and operationalizing what SDOH is, as opposed to just keeping it as a task. Not that anybody on this call is doing that, but it is something naturally that we start to do is I have these tasks to complete. So the social determinants of health can give us cues on needs or supports or encouragement that we may be able to help help our organization with. Are there training? Is there an opportunity on understanding certain socioeconomic factors that are influencing outcomes? Are there family characteristics? Are there linguistics that we need to be mindful of? And how do we communicate those? So a great team-based approach through that. Our infection control systems continues to be the driver of noncompliance in the organization. And when we think about infection control references following all of the CDC recommendations in every category possible, it can get overwhelming. But we just go back to the basics. And I think that's the key is what was old is new again, back to the basics and keep us that foundation that's healthy and necessary for how we can move forward. We see that the citations come about and break down core practices. And there's the philosophy that we incorporate with individuals that's been around for as long as I've been an administrator, of practicing how we would behave if a surveyor was in the building every day. And that sounds wonderful. We all know that when a survey walks in, it does get your heart pumping a bit. It gets a little more intense. Even if you are if you're still preparing the same way, I usually would think, oh goodness, did I wash my hands the right way? And I just keep washing. So that doesn't build a lot of confidence because I'm nervous and nerving myself up. So think about how we can engage our teams and how we can celebrate our teams and we can acknowledge that this is a stressful time. But recognizing that when I catch you doing something good, maybe you have an employee spotlight board or maybe you put into a drawing on the people that are really caught doing exceptional work or caught doing something to standard and just building that excitement up. And so when you have survey going on, you're still doing the excitement. You're still giving those treats and treasures out and acknowledgement out just to keep that morale up and help to calm that down. Outside of survey, having breakdown core practices and getting busy on the task at hand has an impact on what we see on the outcomes. Inadequate surveillance and response planning. Do you have your tracking systems in place? Are you monitoring ongoing on your line listing on what potential infections are going on? Are you monitoring your antibiotic stewardship program? Do you have an antibiotic stewardship program that needs a little polishing? Are we looking at and tracking for potential transmissions and catching items before they start going forward? Are your teams, when you're rounding, are you keeping an eye out on practices that may need a little polishing to help prevent spread before it becomes an issue? I think the effectiveness of staff education and competency validation just really can't be highlighted enough. One of the most embarrassing conversations I've had with a surveyor, and it wasn't anyone's, it was just a process opportunity is what it came down to. When we had been doing training on abuse and abuse prevention. It was almost on a quarterly rotation. It was just part of what we did. We had our name badges. We had the guidance of what you have to be reportable on those name badges. We had it in our annual education. We had our ongoing staff checkoff sheets. We had our competency documentation in place. A surveyor walked up to me during survey and said, with an environmental services professional from our team, and said to the professional, "Tell her what you told me." And the professional was crying, broke my heart. why are you crying? What's happening? And she said, surveyor said, I don't know if you know this, but this woman's illiterate, which is not probably the best delivery. But we found out that her teammates, this woman could not read well. Her teammates felt bad for her and would give her the answers for all the tests. And so it was an eye-opening experience for me to recognize that um, thinking about the social determinants of health, there's a stigma that people have, and that they're not always going to be forthcoming with what their challenges are. So when we think about our competency systems, when we think about what our education validation systems are in place, we want to ensure that we also have those check-ins to ensure that people understand. And so we modified our approach after that conversation just to add on random discussion. Like, hey, can you tell me what the reportable drivers are? Let's just add that in. And if you did well, your name got put into a drawing. We one of the best. Each building had its own culture of what made the most sense. But one of our most successful drawings that we did was each month had a focus. So as we're getting in back to school time, we would create two backpacks, for example, stuffed with school supplies, lunch boxes, everything for a boy and a girl. And then people during that month's drawing of doing something good, we put your name in, and then we would draw. And so a family would get a backpack for their children to start school with. And I think in November we did was when the pressure cookers came out. So we did a pressure cooker for someone. So minor things that are expensive, that are really nice, that a lot of our teams maybe not have the ability to afford right now. Having that as a raffle item doesn't cost that much money. It gets excitement going, and it gives us an opportunity to build that engagement with our teams. And so by doing spot checks with our teams and saying, can you tell me what these things are? Can you tell me the number, how to prevent infection control? What do you do for hand washing? And people that do that right get put into the drawing. Now we're validating that if there is an issue that's in place for education, we can work with them, even if there's a stigma that someone doesn't want to say they don't understand a topic or they don't understand what the questionnaire looks like. I know one of our tests that I took for infection control in a facility was written at a registered nurse level. And I am not a registered nurse. I'm a huge fan of registered nurses, but not in my skill set. And I struggled on that test. I really had a hard time answering the questions to pass it, and thought, how is anyone else passing this? This is heavy in the physiology of infections and the microbiology. I don't know how we're doing it. So we brought that down and modified it so that it was more digestible for everybody. Um, it has to be something that I can understand too. So we want to ensure that we're checking those systems. Another area of compliance, just to keep in the back of your mind, is do a check-in and validation of the isolation and the cohorting practices. This is really important. It's good to keep an eye on that. It's not easy to make the interpretations, and we know the enhanced barrier precautions have brought about their own level of confusion over time. And so think about how you're incorporating isolation, cohorting, and enhanced barrier precaution work in what we're doing. Workarounds and safety risks is a huge opportunity. So much so in one of the facilities I worked at, we started doing a question as our interview process of asking standard for everybody. Do you wear your seatbelt, and why? And the reason we asked that is because of the responses that we would get. You'd be surprised at the number of people that would say, I wear my seatbelt because I can't figure out how to make the beeping stop. So what that tells me is that this is a wonderful person, an honest person, but it's a person that's going to figure out the workarounds and any safety programs that we have. Workarounds can have a significant impact on outcomes, on safety events, resident quality of life, and staff safety events. If we skip our safety checks, if we are not consistently following our protocols, if we're not responding to requests for call out or help, if we aren't mentoring and counseling our team members to be successful in these practices, then people can get hurt. Beyond the compliance perspective, this can have a significant impact on the organization. And so, being a mentor, being a supervisor is challenging and difficult. And we want to ensure that we're supporting our teams to be have their highest level of success in this work. We need to help them understand the importance of rounding or how to do education appropriately. In quality improvement, we have a saying that over 90% of the issues that happen or occurrences that happen are not people related. It's process, it's system, it's education related. So keep that heart in the work that you do helps to look at what might be driving someone to be non-compliant in an area, a team member not following a practice. Understanding why they're doing something helps us to address those barriers and improve the outcome on a broader perspective. So keep those opportunities coming, being present, doing the walking rounds, talking with our team members, all great options for us to maintain that awareness and move that work forward. Supervision and accountability follows through on those workarounds. So it's not just about doing the mentoring, it's also about ineffective delegation or unclear authority lines. Do your supervisors feel that they have the ability to provide that education and counseling? Do you have a system for how you're capturing that information? Because if we didn't document it, it didn't happen. But do they feel empowered to be able to do that? Do people understand what they can delegate and what they can't delegate off? And how are you validating and checking those things? When you have a performance issue, are you following your systems consistently through your processes? And are you looking and doing your investigations appropriately? And ensuring that you have that documentation is critical to what we do. Communication and collaboration is another arm of how we can work this through. This can't be driven by just one person. It's got to be a team-based approach on how we support our organization to deliver that high quality care and high level of engagement that we're looking for. We want this to be a wonderful place to live, a wonderful place to stay for rehabilitation and head back home on, and a great place to work. That's our common commitment as leaders in the field. And so how do we engage our teams to be successful in that? If we're not using appropriate shift-to-shift handoffs, that can have an impact. There's lots of discussion about how to do handoffs. And I know in my past, if we gave 15 minutes to do a handoff, and that's what it would take to do a handoff, several times I would just say, you just need to do a handoff. That's what the expectation is. And so walking rounds need to be accomplished. And if it takes you 5 minutes to do it, great. If it takes you 15 minutes to do it, great. If it takes longer than that, we've got to figure out why. We need to look to see what the barriers are happening so we can mentor on how to do it more effectively or more efficiently. But we need to allow that time to be able to do those handoffs and put eyes on what's going on for our resident care. Also, break down interdisciplinary communication. If we start to silo off, is that this is your job and this is your job, then we're going to have a breakdown where our care plans aren't going to match, our assessments aren't coordinating, and we're not thinking about the whole person. What makes Alyssa unique as opposed to Peggy? We're all unique in what our wishes are, what our wants are, what our preferences are. And we need to ensure that our teams are honoring those and that they're aware of those. So our care plans are reflective of that. And then we're engaging our team members in that. Concern management is a big piece. We've kind of talked about this with our guardian angel rounds of being present with our residents and hearing what their concerns are. I would much rather know the down and dirty, what's happening in the organization personally, keeping those lines of communication open without a lot of retribution or fear of retaliation. Let's talk things through and let's work them through to get better, because it's systems, education, process issues. It's not people issues. So let's move that along, as opposed to having an external visitor coming in and telling me what the problems are. That's not great. We want to be able to have that culture where we address that internally. And then we take credit for it. Sometimes we have families or residents that just had lots of opportunities for us. And I would have my folder all ready with copies of the concern forms ready. So when survey walked in for a complaint, I knew what was going on. It was all organized and ready to go. And This is what we did to try to resolve it. On those concern forms, just as a side note, if you're not doing this, it's a good opportunity to take a peek at it. Ensure that you're documenting at the bottom, was this successful? Was the person satisfied with the response or not? If they weren't satisfied, try to come to a resolution. If you can't come to a resolution, it's important to note that. That gives us that documentation, excuse me, to show what we were doing at the time to try to resolve the concerns. It's helped me more than once to be able to say, I'm surprised you're here. We had come to a resolution on this at this date, and I came back and checked in resident council, and there wasn't any more issues on this. So I'm surprised. Do you think this has been resolved? This gives us that documentation and that story for our visitors that are coming in. And then missed opportunities for team problem solving. Huddles are a great tool, and they've kind of fallen away over the last several years. So it's back into that what was new is old again, or what was old is new again approach. Huddles don't have to be a significant amount of time, but it sets the tone for the day. It's like the team group before we get going into the basketball game. We're all getting on the same page. We're talking about what's going on. We have the same plan, and we're giving each other that support and encouragement for a great day. This can happen whether the leaders are in the building or not. All shifts should be doing that team huddle. Your nurse supervisors can lead it on midnight shift. Here's what we have going on. Here's what here's the people we're going to watch for the day. Do you have any concerns that you picked up on from shift to shift reporting? All of those are important. And then think about how we're flowing that into our morning stand-ups, or if you're doing stand downs as well. How are you flowing that information into those meetings and then flowing them back out? So if you have a morning stand-up meeting, that should be on the shift to shift huddle. Here's what we have happening for the week. It's a great time to do a shout out. Hey, great job, Pecky, for your work with Mary. We were so excited to see that she got a bath and she was singing songs and was really happy the next shift. Great job. We appreciate you. Easy stuff to kind of flow that through, but it's really important to be able to build that comfort level that what you see, what you know, what you're experiencing is important to what we're doing. And we can validate that our systems are in place and moving. It's a good way to check if you're seeing behavioral concerns on your shift to shift, but not in the computer. Now we know that there's a training opportunity to come back around to or mentoring. So look at what you can do to bring those opportunities back into place. They are meaningful. It does engage the staff, and if done right, it's not a significant amount of time and is offset by the mitigation of your process issues from survey complaints, from fines from CMPs, and most importantly, it's offset by unnecessary hospitalizations, unnecessary ER visits, or staff injuries. Engaging and building relationships is a foundational approach for what we do across the board. We want to ensure that we have our family involvement in the discussions that we're doing. And our survey results show us that minimal involvement of residents and families in the care decisions are leading to several of the compliance opportunities. So how are we engaging our families? How are we talking to our families about what's going on? What are our families saying to the survey team? Are they engaged with us? Having that staff perception of lack of support or recognition, or feeling that if they say something, it's not heard, comes through in our systems. We talked a little bit about that two-way mechanism, that information can't just flow one way. It's not a river. It comes in and goes out, and we have that communication happening. And how this can be used for the identifying those early warning signs so that we can prevent issues, errors, or accidents from happening is critical. So an engaged team, an engaged family, an engaged resident support all helps us move this work forward. One of the other things that I learned about a couple years ago, if you were in Leadership Academy, it was talked about, but great opportunity. Think about your huddles when it comes around accidents, or huddles around behavioral outbursts, or huddles on abuse prevention systems. Talking with the team, with your team, your frontline team members, pulling them together after a fall, a bedside huddle with that group of saying, what did you see? What do you think was the contributing factor to this? If you could change something, what would that be? Just a short conversation while you're getting the the witness statements of the event helps to get a picture of what else was happening that can help you solve the problem. And it builds that confidence of our frontline team members of what they can do. 3 times in my career, sadly, I had short-term rehab residents that attempted self-harm by wrapping a call-light cord around their neck. And all 3 times that was prevented by environmental services professional catching the call-light response immediately. It wasn't nursing, it wasn't therapy, it wasn't social work. It was the environmental service professional on the floor that saw the call-light go on, poked their head in to see what they could do to help, and identify that there was that significant error. Our environmental services team are critical members of our frontline staff team. So when you're doing these huddles, ensure you invite them. Environmental service teams, your floor care team. If you have dietary staff on the unit, passing things at the time, get their perspective. Activities staff, all critical to understanding what are they seeing and experiencing, and are really assets as our nursing assistants, our nurses, our therapists. Okay. Whew. Common drivers. Not surprising, but good information as we're thinking on systems. How do we move these systems forward? So what are some of the strategies that we can do? There was a study that was done in 2024 about asking the nurses, what is the one thing that mattered most to you? And the nurses that responded kind of made this is our top list. If they did one thing, this would have the biggest impact on the organization. Rounding more consistently, asking residents and family about their experiencing, observing communication with residents and families. How are staff talking to people? What's the conversation like? Are they involved? Developing stronger relationships with new team members, more time mentoring staff members, developing supervisor and charge nurse leadership skills, becoming more approachable, talking less and listening more. And that is hard. That's a hard skill to develop for some of us. Become more proficient with technology and set better boundaries and lead by 5 p.m. That one's interesting to me. In organizations where we provide so much, where we give so much, it's not always easy to have those boundaries in place, but it communicates loudly to our team members. If it looks like we have to be there all the time, it shows that we don't trust our staff, that we don't trust that their skills, their competence, their leadership. So we want to ensure that we show and demonstrate that, and that while we're available, it's always that statement of, you'll never have to worry about bothering me. I'm always here for you. Just give me a call. I'm going to lean on you to let me know how I can support you, is a good way to build that relationship where you're not hovering over them, but you're there to help them when they need it. And so we can keep those boundaries in place and still keep those relationships going. But a lot of this, what we see here is this one thing that would have the greatest impact really aligns with what we previously talked about: relationships, engagement, spending the time to support the team members that we have has that impact on the operations. I challenge you to think about, what is that one thing that you could do that would make the biggest difference for your organization? That's the thing that we should focus on. That should be our goal in the upcoming year, is I want to focus on this one thing. The other piece that made it and keep it in perspective for me is keeping a mindset of, where am I spending my time? So if I'm thinking about what my time is committing to and what's the most important priorities of the work that we do, that helps to drive where my resource and attention is focused on. So I knew if I focused on resident and family engagement and training staff and keeping a leadership focus, and doing QAPI on the process opportunities that we have. So resident and family engagement, leadership training and staff training. If I'm doing walking rounds, if I'm recognizing people for doing a good job, if I'm driving that focus forward, everything else works out. Surveys are better, satisfaction surveys are better. Ultimately, our census is maintained or improves because we're doing the right thing and it's a good place to work and people like being there. And then the budget works. So not on my priority list was penny pinching the budget, because if I focus my attention on the team, the residents, the families, my walking rounds, and working with the team on fixing the opportunities that we identified, the rest of it worked itself out. And I think that's the thing, is that it can be overwhelming when we start looking at all of the pieces. But if we break it down to the basics, we can really have that significant impact. So leadership action steps, doing your roundings, doing the spot checks and validation, that's QAPI in its best. We're just gonna, these systems are in place. We did the training on them. Let's just validate that they're still moving forward. That you have the development and the mentoring programs in place, and that you're committing to that you're committing to the engagement levels, that you're building that culture of transparency where there's not a fear of saying what's happened, because over 90% of the things that occur are not people related, they're system and process related. Then we can build that confidence of our team members into reporting that. Facilitating that structured and interdisciplinary collaboration and working across the departments, thinking about how we keep the residents at the center of what we do and elevating those important values that are and preferences that are of value to the residents and their family members is going to help us to have the best care plan in place for them. And we want to review that with them to ensure that the families and the residents are okay with it. When they sign off on it, there's another level of documentation that we have available to say, we reviewed this on this date and we were okay with it. And then we did a double check and made sure it was okay. We're not aware that there was a change or a problem. And here's our systems that we have to show that we're routinely validating that we're moving ahead. It mitigates those compliance risks. So how do we put it all in action? Well, we need to start small. We can't eat an elephant by swallowing a whole. It's one bite at a time. And with that, we just take it one piece at a time and celebrating what those next steps are. As a baby administrator, was working for an organization that we were a one-star facility, had some significant opportunities in place, and we're part of a large corporate family. Our facility, the corporate family had a dashboard of probably 20 indicators on a weekly basis and how you were doing with them. And we were routinely in the red on all 20 areas. And it was really disheartening. Every week I'd get the report, and every week we'd still be red in all areas. And every week we'd have to have a conversation about it. And it dawned on me, it doesn't matter how disheartening and how sad it is to see this dashboard that the colors aren't moving forward. It's disheartening for all of us. It's not that people are trying not to do a good job. It's that systems, processes are coming into, and we're having barriers with it. So we made a commitment as a leadership team. Like, you guys don't want me sharing this report with you. I don't want to see this report anymore. Nobody likes to see us in the red. Let's try in the next 2 weeks, let's try to get one indicator in the green. So let's all decide as a group, what's the one thing that we can do? And as silly as it sounds, our goal was to process payroll on time. That is so important. It is really important to our staff members. It's important to the organization. And it seemed like it's an easy one to do, but we struggled with it every week and we were always late. So that was our goal. The whole team was going to work on, let's get payroll right in the next 2 weeks. And we did it. We turned one green and we celebrated. I love hot dogs. I love a good hot dog. And so we got the grills out, we had hot dogs, we had dessert, we had ice cream, and we celebrated. We made it green. And now we still had 19 other indicators that were red and had been red, but we turned one green. And I think that's the piece, is that it's easy to get overwhelmed by all of the things that have to be done. And we forget that we are making progress one area, one step at a time. So take that time to just pick and start moving forward on it and work as a group with it, as a team. Now you're moving that along. When we can commit to that one area, we can have that celebration. And within 6 months, we had 50% of our measures were green. They weren't all green, and we weren't always green, but we made significant improvement and had, by the end of my tenure at that organization, we had gone to a 5-star facility. We had improved our census, improved our retention rates. It was a great place to live and to work. It was amazing to be at. And I think about that organization and that team so much, about how much we accomplished. We can do that anywhere, just taking it small, moving that forward. When we're talking that areas, we want to communicate what the risk area is and invite the solutions in. And it's good to share what this means. How many facilities or how many teams have you talked with when you said, why did you get cited for that? And they said, because they were picking on us. This isn't a us and them is a situation. This is trying to understand what was the level of compliance and what didn't we do, or where's the opportunity. So talking to explain that to people and helping to gather that insight from them on what is our steps forward and starting to try those. Then you strengthen that communication system. Use your huddles. Use your shift to shift reports. Use your recognition tools to communicate how the status of that project you're working on, and document that in your copy. Most importantly, don't forget to celebrate. It can always get disheartening of all the other things that you have to do, but we need to be able to demonstrate how we're moving that forward. So we might be doing regular in-services on practice standards or ethics. We might want to ensure that our staff are adhering to licensing scopes and clinical protocols and working within their scopes. Sometimes we have people that work at a very small level, but we might be able to expand that and empower them with training and support and education. Hold monthly risk reflection huddles. I've heard them called different things where you're talking about your high risk areas. Bring that to your department meetings. Ask your department meetings what they're seeing. And it's not just nursing department. Dietary team can give us significant insight on what they're seeing happening on meal trays coming back. Are they seeing concerns that they have when they're delivering trays, or that things aren't being passed timely? That's a clue to us that we may have the wrong times in place, or we may have the wrong acuity mix on a unit because we're not able to get to the snack passes. Lots of insight that we can have from involving those teams. Create those open channels and encourage that solution-oriented suggestions. That's tricky. And I think that it's important to note that, at any point in time, we know 20% of our team are going to be the early adopters on anything. They're going to be the ones out there driving the work. And we're always going to have laggards. I saw a leadership study that talked about this a couple of years ago that compared it to being in a boat. That you have 10 people on a boat, 2 people are actively paddling that boat forward, and 3 people are actively throwing anchors. We're not going to change that. It's just the way that it is. You have those 3 anchor throwers and those 2 paddlers. Where we can have the impact is, what are the 5 people in the middle doing? Are they cheering the rowers on, or are they cheering the anchor throwers on? If we can get that focus on the people moving forward, and we can keep those 5 people focused ahead, now we've got the majority of our team in that solution-oriented discussion. They're part of what we're doing. They're part of what the outcomes are going to look like. When we empower them, it starts to drown out the anchor throwers, and they either lower the level or they stop. In some cases, they leave. But they're always going to be there, and they're kind of good to know. I always look to them as, if I'm going to fail, they're going to tell me how I'm going to fail. So we need you involved. You tell us how this is going to work, and we can make sure that we mitigate those risks. But you're not going to be the ones driving the process. This team is moving this forward. Do your root cause analysis, do your huddles for that bidirectional flow, and develop an agenda for how you're using QAPI going forward. I'm not sure if you've noticed or if you've seen, but survey is really looking at what you've been doing for the last 2 to 3 years of survey citations when they're coming in. And so if you're getting recited in the same areas, now you're going to open up to a QAPI citation. You're going to start getting into the quality action and the leadership and administration citations, because we're not stopping or we're not shifting what that looks like. So part of your QAPI agenda should be highlighting spot checks on what those previous citations have been in the last 2 years, just to validate that they're continuing to work and they're moving forward. When we think about working through processes, bundling is a great tool to be able to think how you can have a significant impact with limited amount of resources. And we're nothing if we don't have a limited enough of resources across the industry. So I was looking at that top 25.
What's going on with Maggie?
Okay.
When I look at the list of the top 25 citations, they kind of group into areas. And so our standards of practice are listed: infection control, trait care, suctioning, all kind of falls into the standards of practice. Then our drugs and biological processes are kind of in a section. Abuse prevention groups and pops out. Care plans and assessments pops out. ADL support and work pops out. And then our others are other things that are going on in the organization. And so if I'm thinking about this from a team approach, we may start with what is our biggest area of opportunity. Maybe in our organization is ADLs. So let's pull together some representation in our team. Let's ask them, we're going to focus on ADLs. We want to be able to move this forward. We've done our assessments. We have this concern. So what are some of the barriers that we have for doing ADL work? What are some of the things that you're seeing? If you could change anything to fix it, what would you do? And taking into account that we may not be able to do staffing changes, but let's put anything else on the table and just generate some ideas and then come up with your action plan and start working it. You run it through a copy. Now you're starting to move that work forward. And if you need to adjust it, then pull your team together, make the adjustments, do your training, monitor for the effectiveness of it, and then move that forward. Once you get your system in place, 6 months later, do a spot check on it. Is it still functioning like we thought it was supposed to? Or did it kind of fall back to the wayside? We just need to do a refresher on it. Great tools to bring back to the table and keep that focus going on. On this grid, just so you know, the number underneath the F tag represents how many times it's been cited within the citations that have been issued in 2025. So F880, not surprising, it's our number one citation. 32% of the facilities that were cited received that citation. Whereas F761, 17.7% received that citation. So good information to have, kind of see where we have those high areas of opportunity. Some key takeaways, and then hopefully a few minutes to talk about any questions that you may have or suggestions that you may have. It's important to know what the top survey citations are and identify those risk areas. It's a great tool to bring into your CWAPI to do a spot check on. And if you haven't done them, take a look at the care pathways that exist from the survey citations. That gives you all the questions that you're asked, that the surveyors are asking when they're coming into the facility. We did a presentation on that back in April, I believe, April or May. So it's on our YouTube page if you haven't seen it. But it gives you that guidance on how to take those tools and use them for checking and validating your systems. We also recently published in July the actual supplement on how to bundle using those CMS survey pathways into your CWAPI. So that is a 12-month calendar that's been built out, bundling a couple of those items, keeping into consideration how we bring in the facility assessment tool, how we're looking at our staffing competencies. That is on our website. It's under the resource page, under the blogs, and so you'll be able to find that. If you can't find it, let us know. We'll send you a copy of it, but it's a nice tool that you can modify and use for your organization to bring those care pathways and that focus into your CWAPI program. Develop a plan to address the common drivers of noncompliance that you see in the organization. Based on that list that we have, are there any areas that are ringing true as an opportunity for you, and how would you start working small in those areas to see the improvement? Prioritize communication and collaboration as a big area of opportunity for the organization, ensuring that you have that multi-directional flow of information, that you have those huddles, that you're garnering that feedback, not just from our staff, but also from our residents and from our family members and any of the external partners that you have. Like the ombudsman team is a fantastic team to have a relationship with, to hear what their experience is when they're in the organization. Move your action plan forward. Start small, celebrate your successes, and commit to mentoring throughout the plan to have those greatest outcomes and successes. If you have any questions, we're here for you, but I'd love to open it up to see what thoughts you have or anything that you're using in your organization successfully.
Alicia, that was a fabulous presentation. Thank you so much.
Thank you.
The CWAPI tool you were talking about at the end that's on your website, if that is something that you're willing to just send out without us having to go look, would be, I know, helpful as we're trying to connect the facility assessment as the regulations have gotten more and more embedded. with that terminology as I was just rereading over all the infection prevention tags and how the assessment has to be physically in that facility assessment. So that would be, I think, very, very helpful.
That's a great suggestion. Thank you, Patricia. Olivia, would you mind sending that out, including the attachment with these slides to everybody?
Absolutely.
Fantastic. Thank you. Great suggestion. Anybody else have any thoughts or things that you're seeing that is helpful to consider? Or any programs that you're using that you'd like to share with us as best practices?
Anyone with any recent survey that have been completed and any feedback that would be helpful to share?
Great question.
Okay, we have a quiet group, and but thank you everybody for joining us, and thank you, Alyssa. This was excellent and very helpful. And I want to ask everyone that's joined us to please complete the survey at the end and give us some feedback on any future topics you would be interested in. And also join us in September, on September 18th. We're going to talk about infection control and infection prevention. Talk about vaccinations, antibiotic stewardship, tracking and training. So that will be our quality leader session in September. And then in October, we have someone from Teepa Snow's company joining us to talk about dementia care and staff education. So please join us the third Thursday of the month at 11 o'clock. And again, thank you for joining us.